Shall we start? Hello, everybody. Good morning, good afternoon. I'm Anastasia Mihailidou from Royal North Shore Hospital, Sydney, and the Colling Institute. It's my immense pleasure to welcome you here for our first American Heart Association journal's Hypertension, as you see from the background, our digital strategy editors webinar, Hypertension Impact, on one of my passions and everybody else's here on blood pressure measurement. This is timely because, as you know, May is Measurement Month, and we, particularly this year, it's the 20-year anniversary of Know Your Numbers, and the theme is measure your blood pressure accurately. So I'm delighted that we've selected this topic, and we have such great leaders in the field of blood pressure measurement in their respective areas. And so we're not only covering clinical as we usually do, but also in experimental, which is vital if we want to have mechanism-based treatment. So I'll introduce each one individually, but I'd like to welcome Dr. Jordana Cohen, Dr. Pierre Paradis, Dr. Lara Kovell, and of course, the fantastic Dr. Diachi Shimbo, as well as my co-hosts, Dr. Carmen de Miguel and Dr. I'll say Guto instead of Augusto, Montezano. Welcome, everybody, and we'll get started. Thank you for joining. And of course, I shouldn't forget our fantastic coordinator, Trudy Mayer, who we wouldn't be able to bring this to you. So thank you for joining. So we might get started with Dr. Jordana Cohen. Dr. Jordana Cohen is Associate Professor of Medicine and Epidemiology in the Renal Electro and Hypertension Division at the University of Pennsylvania. Her research examines physiology-driven pharmacologic effects of antihypertensive medications in high-risk patients. She's chair of the AHA's Hypertension Science Committee and co-chair of the Chronic Renal Insufficiency Cohort Blood Pressure Working Group and the American Medical Association's Blood Pressure Validated Device Listing. Welcome, Jordy, and look forward to your presentation.
Thank you. I'm so excited to be talking about my favorite topic, why measuring blood pressure accurately matters so much more than we give it credit for. I've got no relevant disclosures. So this graph is from a publication by Paul Muntner. It's a little bit outdated, but it was using National Health and Nutrition Examination Survey data and demonstrated the magnitude to which blood pressure control in the US has been declining over time, which has persisted since this was cut off. This is similar in other countries and is really an unacceptable trend. And I think there are several factors that likely contribute to the decline in rates of blood pressure management in the US. But first and foremost, the one that we can control is physician inertia. And I'm going to spend today talking about how I think that blood pressure measurement and accuracy is one of several drivers of clinician inertia, and one that we can control and can immediately fix if we put the time and effort into it. It's unacceptable, and these are preventable outcomes that we would be able to see better outcomes from our patients if we address this appropriately. As we've been fortunate to have more sophisticated trials demonstrating the value of more intensive blood pressure lowering, this has increasingly been reflected in guidelines, and we're seeing lower and lower thresholds now in our hypertension guidelines internationally. But now that we're aiming for these lower blood pressure goals across entire populations, I think this more than ever underscores the importance of accurately measuring blood pressure, particularly if we overestimate blood pressures in individuals where we're aiming for lower readings, we can result in harm and overtreatment. And it's something that I think really gets overshadowed by other aspects of hypertension care. There are several factors that contribute to measurement inaccuracies. I'm going to go into a lot more detail into some of these, but here's a list of examples of common errors in routine measurement of blood pressure, and their very substantial potential impact on both falsely increasing and falsely decreasing blood pressure. Keeping that in mind, it can go in both directions depending on the factor. We also encounter particularly issues of measurement error due to the devices we use. I imagine Dr. Shimbo is going to go into quite a bit more detail on this than I am, but we previously used mercury devices, which were perfectly precise for many decades. but they were prone to human error. And in the past 2 to 3 decades, we've been forced, due to the potential environmental risk of mercury, to transition to aneroid devices, which are both imprecise and prone to miscalibration, prone to human error. Or oftentimes better, we use automated devices, but these reduce human error, but they can still facilitate, a larger number of readings, which can also help to regress towards the mean and improve accuracy, but they still require validation. And I've included here a list of validated device listings that exist internationally, but often we are using non-validated devices. So I hope to spend the next few slides convincing you of how inaccurate blood pressure measurement can have very important ramifications in terms of delayed or overdiagnosis of hypertension, or overtreatment and undertreatment of hypertension. We know as clinicians that time is our most valuable and scarce resource, and that it's understandable that many people feel that we don't always have the time or support to perform the highest quality readings. But I really think this needs to become a top priority rather than something that's just cast aside among so many other checklist items that have to happen in any given visit. So next I'll talk about how much of a difference can one blood pressure measurement really make. This is a figure from a paper that was led by Paul Draws at the University of Minnesota. He went through an enormous amount of effort to track down electronic health records for as many participants of the SPRINT trial as he could. And he compared routine clinic blood pressures that were performed on the same day as perfectly accurate blood pressures performed in the SPRINT trial. On the y-axis, you can see the difference in those routine clinic blood pressures versus standardized trial quality blood pressures. Interestingly, routine clinic blood pressures could be as much as 40 millimeters of mercury higher, but also 20 millimeters of mercury lower than trial quality blood pressures. The average was higher, but they go in both directions. And there was really no clear predictor of whether somebody would have a substantially higher or lower or close to true blood pressure in these routine clinic readings compared to those trial quality blood pressures. My takeaway from this is that a lot of what we see from these differences in routine clinic blood pressures versus the trial quality blood pressures isn't some important physiologic difference, but it's random measurement error that could be having enormous impacts on our treatment decisions. Here's another example of diving in deeper to specific components of that measurement error. Tammy Brady's team at Johns Hopkins performed a series of really elegant and fascinating trials where they very simply evaluated the impact of individual aspects of blood pressure mismeasurement. So this example was a crossover randomized control trial that they did of 195 adults who each underwent 4 sets of standardized blood pressure measurements in random order, using 4 different cuff sizes regardless of what their appropriate cuff size was. When participants were overcuffed, so they had a blood pressure that was too large blood pressure cuff that was too large for their arm circumference, they had as much as a 5 to 8 millimeter mercury lower blood pressure than when they used appropriately sized cuffs. When they were undercuffed, which is what we tend to think of more often, when they used a blood pressure cuff that was too small for them, so somebody who was an extra large arm circumference but used a regular cuff, for example, they could have as much as a 3 to 20 millimeter of mercury higher blood pressure. Most blood pressure devices sold in the US just come with one regular blood pressure cuff, except approximately 40% of US consumers don't have arm circumferences in that regular blood pressure cuff range, which means that their blood pressures on average would be overestimated by almost 5 millimeters of mercury, if not more. The authors estimated that an error of 5 millimeters of mercury globally could result in misclassification of 84 million people who could either be undertreated or overtreated for their hypertension or under or overdiagnosed for their hypertension based off of these simple mismeasurement errors. Arm position also has a really interesting and big impact. This is another crossover randomized trial performed by the same group, where they enrolled 133 participants and compared 3 different arm positions in random order. Either appropriately supporting your arm on a desk, supported in their lap, or unsupported dangling at the side, which has happened to me at so many clinic visits that I've gone to. When individuals had their arms supported in their lap, it was an average of 4 millimeters of mercury higher than when it was resting at their desk. When they had it unsupported dangling at their side, it was an average of 6.5 millimeters of mercury higher. So think back to that 84 million patient misdiagnosis globally with just 5 millimeters of mercury difference, and this is even bigger than that. Similar to the miscuffing trial, then, this could result in substantial misclassification of blood pressure, including over and under treatment and diagnosis. And I really do suspect that this contributes to a lot of white coat hypertension, and in particular among treated individuals. This may be partially why we don't see a relationship of white coat hypertension, or particularly white coat effect, with cardiovascular risk when we look at it in meta-analyses. That these patients who are already being appropriately treated, that office blood pressure reading that's done inaccurately probably doesn't have that much value with regard to their long-term cardiovascular risk. And we have some really important interesting test cases that demonstrate this from a prognostic standpoint. There are several scenarios where we do a particularly poor job, even much more so than just in the clinic, of measuring blood pressure. And we can see what the clinical impact of doing that is. First, I'll use the case of the inpatient setting. Inpatient blood pressure measurement is fraught with accuracy issues. Most blood pressures taken while people are in the hospital are taken while they're lying flat on their bed or even in Trendelenburg position, which is meant to give an elevated reading. They're miscuffed in terms of size. They're often mislimbed. I can't tell you how often I go into and examine a patient in their room and they have a blood pressure cuff taking a cuff over their ankle, and I'm asking, are you getting ABIs done while inpatient? And they're also often done in the setting of other confounders that can impact measurement accuracy, like pain, anxiety, and stress. I do think this is part of why we have growing evidence suggesting that intensification of antihypertensive medication among inpatients is associated with adverse outcomes, because these people probably don't have blood pressures as high as they seem. This is an example of a cohort study of over 17,000 patients admitted in the Cleveland Clinic, where the authors found that intensification of antihypertensive medications for elevated blood pressures while inpatient was associated with a twofold elevated risk of myocardial infarction and with about a 35% increased risk of acute kidney injury. And very similar results were observed by Tim Anderson's group, looking at this in a large national cohort of over 66,000 older veterans who were hospitalized for non-cardiovascular diagnoses, and about 21% of them had received some sort of intensification of their antihypertensive regimen while inpatient for elevated readings. They have found that there was about a 30% increased risk of their composite outcome, which was a combination of mortality, intensive care unit transfer, acute kidney injury, not getting discharged home, and evidence of cardiovascular injury. Another egregious example is in-center hemodialysis. I'll just talk briefly, but there are even more reasons that blood pressure is mismeasured in these patients. Very, very big issues with ambient noise, issues with cuffs over clothing, issues with poor anatomical placement because of axillary access. And it similarly gives us a really poor prognostication of their long-term risk. Dialysis unit blood pressures have this odd U-shaped association with outcomes, whereas the same patients have blood pressures performed in a standardized way. This is data from the chronic renal insufficiency cohort, and we instead see a linear relationship of blood pressure with adverse outcomes in those correctly performed standardized readings. And so in summary, physician inertia is a major driver of inadequate management of hypertension. And I do think that greater trust in the accuracy of our blood pressure readings, including with validated devices and out-of-office readings, can really help overcome that inertia. We as clinicians need to be drivers of prioritizing accurate blood pressure measurements to ensure patient safety and optimize hypertension outcomes. Thank you so much.
Thank you, Jordy, for a great presentation. Can I just remind all of attendees, thank you for joining us, to post your questions in the Q&A box so that we can ensure that all of your comments are taken, and some may be answered by the presenters and some may be live at the end. We'll have an interactive sessions. I'll move on to the next presentation, and gives me immense pleasure to introduce Dr. Pierre Paradis, and I'm very grateful on behalf of our digital strategy team to have one of the leaders in telemetry measurement. Pierre has over 20 scientific publications in just the last 5 years. He is the co-associate director in the Vascular and Hypertension Research Unit and the scientific director of the Imaging and Phenotyping Core at the Lady Davis Institute for Medical Research at McGill University. Welcome, Pierre. Thank you.
Okay, first, I'd like to thank Augusto, Anastasia, and Carmen to invite me to present COF versus telemetry. So first comment from the, there was an important commentary on TELCOF versus radiotelemetry blood pressure from the editor of Hypertension. And what they say is that TELCOF approach can be used to show changes in blood pressure exceeding 15 to 20 millimeter of mercury. But TELCOF is measuring peripheral arterial blood pressure. It allows one-time point measurement per day. It's cheap, high throughput, wherever it is operator dependent, and animals are restrained during measurement. This causes stress. Telemetry, it measures central arterial blood pressure. I cannot see. Okay. The catheter is positioned in the aortic arch. It allows continuous measurement. It's unbiased, however, it's expensive, it's limited throughput, but animals are unrestrained, and therefore this is very good to have good value of blood pressure. Now we'll show you example of study in which we use TELCOF to demonstrate changes in arterial blood pressure. In this study of Tili Barumi, he showed that treatment of mice that overexpress endothelin-1 and endothelial cell in a constant fashion with erythropoietin for 8 weeks, elevate systolic blood pressure in the last weeks, and this was reduced by exercise training in the last weeks. In this ongoing study in which we infuse mice with aldosterone and provide salt in drinking water, we measure systolic blood pressure at day 12 and 13. As you can see, we show a clear elevation in systolic blood pressure compared to the control group, but from day to day, there's variation in the value. In this study of Augusto, in which we use single-cell RNA sequencing to look at the gamma delta T cell subtype in mesenteric vessel with perivascular adipose tissue, we use TELCOF to demonstrate or confirm that the mice infused with angiotensin II were hypertensive and the control mice were normotensive before using the tissue. In this study of Tili Barumi, it showed that angiotensin II induced elevation in systolic blood pressure was completely blunted in mice adductively transferred with T regulatory cell, but not with T effector cell. In the same study, we performed telemetry blood pressure. Here, the results were very clear that the T effector are not protecting and the T reg were protecting. Now we'll show you a situation in which telemetry was the best method to demonstrate changes in arterial blood pressure. In the study of Suelen Coelho, she studied mice that could be induced to produce human endothelin-1 overexpression in the endothelium, and she looked at 3 months. She treated mice at the end of the study with atrasentan and showed that there was a decrease during nighttime and daytime during the last 2 weeks, demonstrating that the elevation in blood pressure was endothelin type A receptor dependent. In this other study of Augusto using the same inducible overexpressing human endothelin-1, she showed that treating mice with apleginone, a mineralocorticoid receptor antagonist, reduced systolic blood pressure during specific time of the day, using our mean blood pressure. This demonstrates that aldosterone contributes to the elevation of blood pressure induced by endothelin-1. In this study of Kujen Ho, we inject microRNA 431.5p inhibitor at day 1 and 7 and show this blunted the elevation in systolic blood pressure induced by angiotensin II. I'm sure we have missed this using TELCOF. In this study of Kevin Como, he showed that initial exposure to hypertensive challenge with a high dose of angiotensin II sensitized mice to elevate systolic blood pressure in response to a sub-pressure dose of angiotensin II, and he showed that injection of antibody depleting gamma delta T cell reduced this elevation. In this study of Brendan Chocopoulos. He showed that high-dose angiotensin II caused a rapid elevation in systolic blood pressure, was delayed and reduced in mice knockout for the purinergic receptor P2RX7. Now we'll show you tips to get good take-off blood pressure. It should be one operator. You should use an isolated silent room, change cuff weekly, test the cuff inflation between acquisition to detect leak, and calibrate pressure with mercury column before the study. You should train the mice on 3 consecutive days at least to get 2 measurement days. The measurement should be done all at the same time of the day. It's better to do it early in the morning. In each session, you should do 10 preliminary cycles to let the animal adapt to the machine and warm up, and then 2 measurement cycles. If you do weekly blood pressure, you need to repeat the training. The mice forget. Tip for telemetry blood pressure. All the surgery should be done by the same person. Calibrate the transmitter baseline in saline before surgery. Do the surgery aseptically. Use new sterile glove to touch the transmitter or fill the catheter with gel. Touch the catheter only with forceps for the instrumentation. These 2 tips are very important to prevent clot formation on the catheter. Use mice of 24 grams or more to facilitate catheterization and allow animal to recover from the surgery for 7 to 10 days. It's important to use an isolated silent room without traffic. Use Faraday cage made of stainless steel to insulate the antenna from the other cage. 1 Faraday cage every 2 cage is good to have a compact setup. During the recovery period, if the pulse pressure decrease or fluctuate or decrease, there is a clot that is forming. If the pressure is varying, changing, it means the catheter is moving. So these mice need to be excluded. This is an example of blood pressure acquisition protocol for angiotensin II infusion. Very simple. You do surgery, you let the animal recuperate for 7-10 days. You start the acquisition for 2 days to get the basal, and then you just remove the cage from the antenna, do the microosmotic pump surgery, and return the cage and finish the study. During the acquisition, if the pulse pressure decreases, unfortunately, you need to exclude the animal from the study. For the take-off, we use MC4000 multi-channel system from Heteros. He has an optical sensor. These other systems, such as the CUDA, will use a volume pressure recording cuff to sense the pulse. For telemetry, we use DSI small animal with the PAC10 probe. There was 1 animal per antenna. There are other systems, such as Stellar, who are from TSC system, who has 1 antenna and the animal can be combined in 1 cage. DSI is coming with such system for blood pressure, but it's not necessarily an advantage with black cyst mice as they fight. I'd like to thank Ernesto Scheffin, who recruited me to work with him in 2007, and Olga Berlioz, and the former member who did all those studies. Véronique Michaud did all the telemetry surgery, all the support we got from with our work and our collaborator. Thank you.
That's great. Thank you. Another reminder, I'm going to do it between each presentation. You'll get sick of it, but please add your questions into the Q&A rather than the chat. We love that you're sending them through. Thank you, everybody, for being so engaging. It gives me great pleasure to introduce Dr. Lara Kovell, who is an expert in women's cardiovascular health. Dr. Kovell, or Lara, I should say, is a non-invasive cardiology, an expert in cardio-obstetrics, women's health, and hypertension. Originally from Pittsburgh, she completed her medical and cardiology training at Johns Hopkins. She is now an associate professor at the UMass Chan Medical School, where she is leading several NIH and foundational awards on hypertension management, cardiac biomarkers, and atrial fibrillation in pregnancy. Welcome, Lara. Delighted you're joining us.
Thank you so
Thank you.
much. Excited to get to talk to you about blood pressure measurement in pregnancy. And it's such a great honor to be part of this distinguished panel here. So if you aren't managing blood pressure in pregnancy all the time, I wanted to show this diagram to start as a reminder of normal blood pressure trajectories in pregnancy, with blood pressure initially declining with a nadir around 20 weeks of gestation, and then an increase of about 8 millimeters of mercury by delivery and a peak about 3 to 6 days postpartum. And one main reason that blood pressure matters is because it's a leading cause of maternal mortality. While this has been improving in many other countries, maternal mortality has been climbing in the US, with several concerning racial disparities shown here. And we know that hypertension incidence and control and lack thereof influences these disparities. Hypertension is estimated to contribute to up to 40% of maternal deaths while increasing risk for both stroke and preeclampsia. Hypertension rates in women of reproductive age range from 15 to 35%, though this is rising along with obesity, maternal age, and fertility treatments. And since it's usually a silent presentation, rates of hypertension control are around about 60 to 70% in these age groups. Now on to some definitions. Gestational hypertension develops after 20 weeks of gestation, while chronic hypertension starts before or early in pregnancy. And these two are distinguished from preeclampsia by new onset proteinuria or other organ dysfunction, though gestational hypertension can transition to preeclampsia, and preeclampsia can be superimposed on chronic hypertension. Like maternal mortality, rates of hypertensive disorders, or HDPs, in the US and worldwide have been on the rise over the past several decades. And this graph here shows us hypertensive disorders as a whole in black and chronic hypertension here in blue. HDPs are associated with both short and long-term cardiovascular risk, including coronary disease, stroke, heart failure, and even death. And as you might expect, the severity and the number of pregnancies impacted by HDPs also increases risk, especially for heart failure. Pregnancy is often excluded, though, from clinical guidelines, making it a fear-inducing clinical blind spot. And this recent review showed that the US hypertension guidelines really gave no guidance about diagnostic or treatment thresholds in pregnancy, though otherwise a very comprehensive document. And these were their main recommendations, that nifedipine, labetalol, and methyldopa should be first-line agents, and we should be avoiding ACE inhibitors and ARBs in pregnancy. This table now is a look at hypertension guidelines across the globe. And you can see here that there's generally good agreement when it comes to diagnostic threshold of 140/90. And the ESC and others have suggested medication initiation at that same threshold, though ACOG and some others use 160 over about 110 for gestational hypertension or non-severe preeclampsia. And we do see here too that goal blood pressures also vary, with more of a focus on a diastolic blood pressure goal in pregnancy. And across these international guidelines, labetalol and long-acting nifedipine are the most widely recommended. Methyldopa is as well, though less favored by ACOG and harder to find overall in the US. And you see here hydralazine, diltiazem, and alternative beta blockers are also seen in fewer of the guidelines. One study that gives us a lot of the evidence behind what we do in pregnancy is the CHAP trial, published in 2022. And it looked at about 2,400 patients with chronic hypertension to decide if what's considered mild hypertension in the OB guidelines is beneficial. And they randomized patients with chronic hypertension to either active treatment with a goal blood pressure less than 140/90 or a control group with treatment for less than 160/105. And they found that active treatment to that lower target reduced a composite outcome, which included severe preeclampsia, preterm birth, and fetal death by about 18%. And despite concerns about placental perfusion with these lower blood pressure targets, there was no difference seen in the safety endpoints of small for gestational age or birth weight. So is lower better? As the AHA and the ACC and as Dr. Cohen showed us, a lot of other guidelines have been lowering thresholds. What about treating stage 1 hypertension? So a pre-specified subgroup analysis of the CHAP trial looked at those who achieved a blood pressure less than 130/80 versus those in that stage 1 hypertension range. And while we lost the benefit of randomization in this study, it looked like achieving this lower or less than 130/80 millimeters of mercury was associated with improved pregnancy outcomes without any associated safety issues. When we look at how low is too low, only the ESC guidelines bring up a lower bound to the diastolic blood pressure, though the level of evidence here is C. And when it comes to what's too high, most guidelines do agree with the ESC guidelines, stating that 160 over 110 is severe, an emergency, and generally hospitalization should be considered for IV medications. Now looking briefly outside of pregnancy, just wanted to start the conversation about how do we get an accurate measurement? And most of these studies, ranging back from Framingham in the 1970s to Sprint in 2015, used a 5-minute rest period and at least 2 readings. And manual measures have given way to more automated or oscillometric devices in these clinical trials. And back now to pregnancy, these are the 2 major studies that we have to guide us, both the CHIPS and the CHAP trials. And there was more variation here with the types of devices used, more manual and mercury devices, still with a 5-minute rest period. And the CHIPS study looked at 2 blood pressure readings and CHAP looked at 1 or 2, depending on the value of that first reading. And how about which devices are validated? This review looked at clinic, ambulatory, and home devices, and they found that the clinic and the home devices passed about 72% of the time. However, only these 3 home devices passed without any protocol violations, and now only 2 of these 3 are still available on the market. Ambulatory blood pressure devices or 24-hour monitoring devices fared worse in pregnancy, and overall 60% of the devices passed, but only 1/3 passed without any protocol violation. So while many blood pressure devices aren't validated in pregnancy or preeclamptic women, there are 2 useful sources here that do help us to find clinic or home blood pressure devices for patients. In the US, we have the VDL website at validatebp.org and a more extensive list at the stridebp.org endorsed by both the ESC and ISH. And here are some of the StrideBP validated devices for home. I'm showing here a portion of the 28 devices they have listed, and these are all upper arm devices with at least 1 approved validation study. And for comparison, these are the 5 devices approved by the US VDL, all upper arm Homedics or Withings devices, though 2 of these 5 are not currently available when I looked this week, and the others range from $60 to $130 each. So given the complexity of device selection and our patients' cost concerns, this is a resource we put together for our patients with a list of devices sorted by cost and features, such as which cuff sizes are offered, since obesity is a common comorbidity and cuff size is so important. And how about how many measurements are needed to ensure control? We don't have a lot of pregnancy studies here, but some guidance from the HINTS trial, which looked at blood pressure measured 3 different ways. And for both clinic and home blood pressure readings, they found a lot of variability, but that it took about 5 to 6 readings to be 80% certain of blood pressure control. So despite other guideline disagreements, home monitoring is widely recommended as a method to help improve blood pressure control and better predict outcomes. And we know home blood pressure use is associated with better awareness, medication adherence. It's most effective if the clinical team is involved. And it does solve some of the problems that we have with clinic-based blood pressure measures and needing multiple measurements to ensure control. We know that postpartum home monitoring can also help improve blood pressure control and racial disparities in hypertensive disorders. Here's the POP-HT trial, which looked at home monitoring versus usual care, and home monitoring here reduced diastolic blood pressure by nearly 6 millimeters of mercury, similar to the recent SNAP-HT study, which was a little smaller. And the TEXT-BP trial also looked at postpartum home monitoring here with text-based reminders and showed that home monitoring could eliminate certain racial disparities versus clinic management. I'm going to take a look briefly at secondary and postpartum hypertension. Though rates of secondary hypertension are reportedly low in pregnancy, it's likely underrecognized. We know that OCPs are the most common drug-induced form in this age group, and CKD and fibromuscular dysplasia should be considered as well. The ESC suggests screening all adults less than 40 for secondary causes. And we know too that postpartum hypertension is pretty common, up to about 12% incidence of de novo postpartum hypertension, even in normotensive pregnancies, and first-line agents, all safe for breastfeeding, are nifedipine, amlodipine, enalapril, and labetalol. When it comes to postpartum management, the study looked at nearly 400 patients with HDPs, managed them with 5 days of oral furosemide versus placebo, and they saw here that furosemide may accelerate blood pressure recovery with HDPs with about a 60 to 74% lower risk of elevated blood pressure, depending on the severity of the HDP. So to summarize, we talked about the concerning trends with hypertension, HDPs, and maternal mortality. We have a few trials for guidance. though pregnancy does remain understudied and more inconsistencies were seen in the measurements in the clinical trials. I showed you two resources for device selection, though selection is limited. And we talked about those diagnostic thresholds, the treatment thresholds do vary. And I showed you some evidence for lower is better, the importance of multiple measures, and how home monitoring and postpartum diuretics can be useful. Thank you so much.
Thank you, Lara. That was great. Thank you. Please, to our attendees, thank you for continuing your questions. Please post them in the Q&A chat. The presenters are seeing them, and we will address each one of them. Now, it gives me great pleasure to introduce Dr. Diachi Shimbo, which probably is known to many of you, but in case we've got people from different parts of the world, he's a professor of medicine in the Department of Medicine in Columbia University in New York. As the director of both the Columbia Hypertension Center and Hypertension Laboratory, Dr. Shimbo conducts translational research into the behavioral, psychosocial, and biological mechanisms that underlie hypertension and cardiovascular disease. He has had many roles in the American Heart Association, but as well as being a non-invasive cardiologist, he's the director of the Cardiovascular Physiology Research Laboratory. He has clinical and research expertise in echocardiography and biomarkers. Welcome, Daichi. Thank you.
Okay, well, thank you for inviting me. Today, I'm going to talk about cuffless blood pressure devices, hype, hope, and hard truths. So I am going to get into some exciting technology. We're going to talk about hype and hope. But unfortunately, I'm also going to go through the underbelly of cuffless blood pressure devices. There are some hard truths. I'm going to ask people to buckle up for this ride because I'm going to go over 200 years of blood pressure measurement. So it all goes back 129 years. We can blame Rivarocci for putting a bicycle tire and putting it on the upper arm and connecting it to the mercury sphygmomanometer, not using a stethoscope, but using palpation to detect systolic blood pressure. And then, of course, we have Korotkov, who used the same bicycle tire put in the upper arm, but in this case, he put a stethoscope on the upper arm, and he discovered that with cuff inflation and deflation, he could ascertain systolic and diastolic sounds, basically the emergence of the Korotkov sound and the disappearance of the sounds. And of course, we call them Korotkov. And that happened almost 120 years ago. And then we also have the oscillometric method. You might be surprised by this. This was invented or discovered by Mary, but the technology actually predates Korotkov and Rivarocci 149 years ago, and basically determined that when you deflate a cuff, the micro oscillations in the cuff actually predict or estimate mean arterial pressure, and modern devices actually estimate systolic and diastolic. Not much has changed. Today, we use the auscultatory method with office blood pressure. We did use mercury. We still use it for validation purposes, but we then moved on to the aneroid device. It still uses the stethoscope and then upper arm blood pressure, but we still use the stethoscope to detect Korotkov sound. So not much has changed in almost 200 years. And then, of course, we have these modern devices. I just told you that the technology for oscillometric devices actually predates Korotkov. And we have used these devices to detect mean arterial pressure, but these devices use a proprietary algorithm to estimate systolic and diastolic. And we use this in clinical practice. Now, that's office blood pressure measurement. What about out-of-office measurement? We have two types, ambulatory blood pressure monitoring and home blood pressure monitoring. And I have no time to go into excruciating detail about these methodologies. All I have to say is they do rely primarily on the oscillometric method. Now, 200 years have passed, and I'm going to go over the status quo. So, for example, for ABPM, it disturbs sleep. This is a study that we did. Look how many people, it woke people up. It stopped people from falling asleep. They removed it during the night because of sleep disturbance. Almost a third actually complained of pain, and another third to about a half of people actually are irritated by the device. What about ABPM success? Remember, you have to wear this for 24 hours. This is a study that we did in Haynes. This is after we trained the staff for a month. And even so, the low bar of getting 70% or more valid readings was only reached in 3 arms. This was a randomized control study where we looked at 3 different devices, only in about 75 to 81% of time. Now, if you look at home monitoring, we give people this device and have it measure it themselves. This is a study that had people measure it for 48 weeks. Unfortunately, 84%, even when told to measure it for 48 days a week, and look how low bar it is. They would just have to measure it 2 days a week at minimum and then 6 times a day. They were only able to get more than half the time doing this. So there's a huge adherence problem. And Dr. Cohen reviews this data. And of course, if you use the wrong device, which by the way happens a lot with home monitoring devices because patients go to the nearest pharmacy to pick up these devices, they don't know any better. But in fact, if the device cuff is too small or too large, you're having really, really big error in blood pressure measurement. So this is where we are. After 200 years, we're stuck in the mud. And we love to actually advance this field. And it disappoints me because when I look at technology, we've had many enormous advancements which was the hunter-gatherer area to the agricultural area. Look at most of the technologies have occurred in the past 100 years. And it's really disappointing that we haven't really gotten anything really to actually move blood pressure estimation along. So the holy grail is if you could create a device that doesn't have a blood pressure cuff, it doesn't use this old-fashioned upper arm oscillometric method or even a stethoscope, uses brand spanking new technology to determine blood pressure, and there's a promise of improved tolerability and adherence, and there's no blood pressure cuff because I believe using this blood pressure cuff actually diminishes adherence and actually getting the device done and getting the appropriate measurements. Well, we have these devices now. There's promising devices. They're called cuffless blood pressure devices. They're in wearable form typically, although they can come in ring or band form. There's lots of different form factors. There's even a toilet seat that's being tested. But again, they don't rely on a blood pressure cuff and an upper arm. They use different technologies to determine blood pressure. So in fact, have we reached the holy grail? I'm going to briefly go through some of these technologies. One type of technology is tonometry, which is a probe is actually pressed on the radial artery. And because it flattens the artery, any pressure in the artery is transmitted to the sensor so you can actually measure blood pressure. Another technology uses PPG technology, same stuff, technology they use O2 sat. And if you have a distal and a proximal sensor, you can actually determine the difference between the wave. And that's called pulse transit time. And you can actually use pulse transit time to estimate blood pressure if you know a particular person that this PTT corresponds to specific blood pressure. We can use ECG and PPG. The proximal portion is just looking at the ECG form, the R wave, and then the distal form is actually the R wave, the pulse that's determined by PPG, and you can actually calculate pulse arrival time, and you can use that to estimate blood pressure. You can also look at the waveform on PPG and use artificial intelligence, machine learning, to actually look at the shape and morphology of that wave to actually estimate blood pressure. That also requires blood pressure cuff calibration, as well as determining it over time and the estimating of blood pressure. So let's do a deep dive. Problem is that these technologies don't actually measure blood pressure. They guesstimate it, and you require calibration to a regular cuff. And the problem with these devices is that you have to calibrate them multiple times. They actually fall out of calibration over time. The second thing is because it requires PPG technology, it's not really sufficiently validated for different skin tones, right? You know this with O2 technology during COVID. But you have to be very careful that is this really good for all patients? The second thing is, I don't have time to go into this, for some reason, these devices don't do a really good job in measuring a sleep blood pressure. And I have some theories about that, but it actually falls down. So are we really just using it to detect blood pressure during the awake period? And then finally, the elephant in the room is, are they actually accurate? And believe it or not, the ruler that we use to determine whether a device is accurate has only been recently standardized. It's not appropriate to use old-fashioned protocols that are based on cuffless devices. We do have the IEEE 2014-2019, which was published, but not many studies actually used it. And then more recently, we have ISO standards for continuous blood pressure measurement. And then 2023, ESH published a protocol. There's not a lot of devices that have actually validated protocols using those more modern devices. So the question still remains, are these devices accurate? Now, this is perhaps the most sobering study. This is a study that actually looked at 4 different kinds of cuffless blood pressure devices: tonometry, PPG, PPG plus ECG, ECG alone. They mixed it with arm posture, and they did it on top of the calibration BP that you take and also the time of day of measurement. I want everyone to look at the green. The green is, and the y-axis is actually error. And anything that's below an 8 is excellent when you compare it to the reference standard. You can see that the green actually is hovering around that line. And this is best of the 4 types of devices that were tested, plus the baseline model. But look at the purple. The purple is just the calibration device and the time of day. And if you look carefully, it actually did better than the measurement that was obtained by the cuffless device. And machine learning didn't help. So if just the calibration BP is the best measure, plus the time of day, why are you even doing a cuffless blood pressure measurement? So this is pretty sobering. The other thing is, we don't actually know whether it serves the status quo. I just gave you this rigmarole. Well, it improves tolerability, it's increased the ability to take all planned readings, and then improves adherence issues, but there's actually no data to support that. The only thing I can tell you is these devices don't have a cuff. So is it a holy grail, or is it a poison chalice? We have to be very careful. I think the way to get there is not only showing these devices are accurate, but we have to actually test these devices in real patients to see it's actually better than the status quo. We have to convince guideline writers that this is the thing that we should be proposing in guidelines. And we should actually look at implementation, because really implementation in the real world with real patients and real providers, and when things are being reimbursed by the US government or regular governments and so forth, we have to test it as well. So at the end of the day, I'm excited about these devices. The problem is I don't know what the future lays in the short term and long term. All I can say is that I have a lot of hope. Thank you so much.
Thank you very much, Daichi. Super Peshakucha presentation. Thank you. Please keep putting your Q&As, and as you can see, some of the presenters are answering them there because we'd like to continue. Now, we're going to have just a brief discussion with our panelists on some of the issues that are arising, and then that may trigger some more questions. I'll start with Dr. Augusto Montezano. Augusto, your expertise in animal blood pressure and is recognized. Could you give me your opinion, or us your opinion, I should say, on the importance, as Pierre highlighted, of the measurement, and if we don't have telemetry, about tail cuff? Thank you.
Can everybody hear me okay? So, okay, perfect. Yeah, so I was very curious to discuss this with you, Pierre, because there is a lot of questions about the differences, not the differences, but when to use tail cuff and when to use telemetry. And I think there's no doubt that telemetry is a much better equipment or much better technique for you to measure blood pressure, because you do see a lot of how do you say, it's more specific, you see small changes that you show in your presentation. But I guess what I wanted to discuss here with everyone, with you, Pierre, is that how do you see that in terms of cost, in terms of labs that don't have the cost to maintain a telemetry, because it is very good, but at the same time it's extremely expensive. It's something to keep. So what would be what would be your perfect your suggestion for you to deal with that the thing? So do you really think that tail cuff shouldn't be used, or do you think there's a usage for tail cuff when and when should you go for telemetry?
Okay, tail cuff can be used, but with caution. So if you see changes in blood pressure and your treatment affect this blood pressure, it's fine. So you have the result, you can publish this, it's fine. But if there's no change, you don't detect changes, it don't mean there's no changes. Okay, so then the question raised whether you should use telemetry. Another situation is an unpublished result that a colleague got when I was at ERCM 20 years ago. He made a neutrogenic mouse. You take the tail cuff, measure blood pressure. The mice were hypertensive. And then we got this telemetry system and start to measure blood pressure. They were not hypertensive on telemetry. So if you use classic treatment, angiotensin 2, aldosterone, it's fine, but you have new transgenic or knockout, and you don't know what you expect, be careful.
So
But in that situation,
I'm sorry,
sorry,
if I
Carmen.
could follow up with that question that you just made to Pierre, I wanted to ask, what is the minimum difference between the groups that you would consider to be a change in blood pressure when you are using tail cuff?
I think in the commentary from the editor of Hypertension, the 15 to 20 millimeter mercury is, I think, a good level, a minimal level. And also, you may, for telemetry, I was able to show change with very small numbers of mice. With tail cuff, you need to have much larger. For example, in telemetry, 5 mice to 6 mice per group is more than enough if you have 2 groups. If you have more group, then you need more. With tail cuff, it'd be more like 10 per group or more, okay, depending on the change.
Okay, thank you.
And I guess like one thing that I would say to emphasize what you have in your presentation, Pierre, is that like the user, the end user is extremely important. Like when experienced in our lab, we had the same cohort of animals, 2 people measuring blood pressure, one person, but just for you to see the difference, like we had to involve like a second person because one person was getting every single animal hypertensive, despite the fact that the animals were trained, this kind of things. But then we realized that that person was very stressful, like in a way. So it is really important for you to train, for you to make sure that the surroundings are perfect for your measurement. So I think like people sometimes don't pay attention to those. They consider like little details, but as Jordy was saying, so like also in the clinic, those little details make like a big difference, yeah, and then can lead you to conclusions that you shouldn't be concluding, right?
So we're going to quick answer, Pierre, and move on to Carmen to say, because we want to answer the questions as well.
Yeah, the operator need to be trained too, and it's not every operator that can do tail cuff.
Thank you. Carmen, just briefly, because of time constraints, give us a commentary about the issue. Lara quite elegantly showed us about the issues of in pregnancy, which is overlooked. What about if non-pregnant women, just briefly, because it's relevant to all the presentations?
Yes, well, I am a basic scientist, so I work with mice and rats, but one of my passions is sex differences, specifically with blood pressure. And as Dr. Kovell saw in one of her presentations, one of her slides, there is a difference in blood pressure between men and women, specifically on how early they start developing changes in blood pressure. However, contrary to what has been believed all this time, thinking that women were kind of protected against these increases in blood pressure early in life, there have been several papers that have come out saying that this is not true, that really the change in blood pressure that women have from when they are younger to, like become hypertensive, sometimes it happens when they are around 30 years old. So this really gives them like a more, I guess that, how can I say, like they are more prone to develop these high levels of cardiovascular disease that we know that is the leading cause of death in women. So my only thing that I wanted to say here is that everybody should be considering to do any kind of studies in both men and women, or male and female if you are working with animals. So that was all I wanted to say. And I guess that another question I had for Pierre, sorry, I am frying you with questions today. I just wanted to ask you about telemetry in pregnancy, just to tie again with Dr. Kovell's presentation. Like, how easy is it to do telemetry in animals that are pregnant?
Okay, I would say you need to instrument the mice before they mate. And let them recuperate from this. And then you check when you keep the mice with the probe, you check the pulse pressure to make sure it's steady. If you start to fall, then you need to exclude the animal. It's happened. So the only thing, instrument your mice before.
Okay, thank you.
Okay, so what we might do is if the questions will be answered in the chat, but I'll go around very quickly and have quick takes so everybody gets a say. 3 take-home messages, Pierre, for people to remember. 3 quick take-home messages from your presentation.
3 tips.
Yeah, quick ones.
Okay, take off when operator. Very important, train the mice. Telemetry, don't touch the catheter just use sterile glove or forceps.
Thank you. Jordy, 3 tips from your great presentation.
Thanks. I'd say accuracy matters. Pay attention to every single one of those steps because every little thing, not waiting long enough, not emptying your bladder, eating or drinking caffeine right before checking your blood pressure can just have an enormous impact on so many outcomes.
Thank you. Lara? Sorry to put you on the spot, but we've actually gone close to time. I didn't realize.
I see some of my trainees too. So I guess my main takeaway is more studies are needed in pregnancy, but think about these diagnostic thresholds and that lower could potentially be better. And of course, the importance of using a validated device.
Thank you. Daichi, great presentation. Take home.
Yeah, so I'm excited about Cuffless. I don't want anyone to get the wrong impression. These are very exciting technologies, but be careful. They're still not ready for prime time. That's the primary message. We have a long road.
Thank you. Thank you. On that note, on behalf of our digital strategy editors team, I'd like to thank the presenters, each for a very informative and entertaining presentations. All of you attendees who've joined our first of the many exciting hypertension impact webinars. Thank you very much for joining, and we hope to see you at future ones. Thank you very much. Thanks.